Hello, and welcome to today's webinar, Breastfeeding in the Community, Implementations That Work. My name is Nakia Sankofa, and on behalf of NACCHO's Safe and Healthy Families team, I would like to thank you for joining us today. Today's presentation is the first in a six-part public health breastfeeding series. During this presentation, our speakers will share lessons learned from the largest national implementation of community breastfeeding support programs. Following the speakers, we will have a question and answer period. During the webinar, all participants will be in listen-only mode. At any time during the presentation, you can enter questions into the Q&A box, and they will be answered at the end of the webinar. So I would like to acknowledge that funding for this webinar and for the um, Reducing Disparities in Breastfeeding through Peer and Professional Support Project was funded by the Centers for Disease Control and Prevention through a cooperative agreement with NACCHO. Presenters for this webinar have nothing to disclose regarding endorsement from an outside entities, and the views expressed within do not necessarily represent those of the sponsor. So our objectives today are threefold. They've been shared with you in the past, but we really would like to talk about the difference between clinical and public health perspectives as it pertains to promotion, protection, and support of breastfeeding. We'd also like to identify core program components needed to implement a local level breastfeeding support program. And we'd like to also talk about at least two barriers and facilitators to community implementation of breastfeeding support programs in underserved communities. We'd like you to be able to list those out at the end of this process. And so a little bit about NACCHO. NACCHO is the National Association of County and City Health Officials. NACCHO, we represent the nation's 2,800 local health departments. Our mission is health, equity, and security for all people in our communities through public health policies and services. The vision is to be a leader, partner, catalyst for the voice for local health departments in order to ensure conditions that promote health and equity, combat disease, and improve the quality and length of all lives. So, what does all that mean? What does NACCHO do? NACCHO strengthens local health department performance, and we do that by providing funding for demonstration projects, such as the breastfeeding project. We also do that by providing training and technical assistance and tools and resources to local health departments across the country. NACCHO is also the national voice for local health departments at the national level, meaning so when something is happening and it requires national voice and national coordination, NACCHO is able to speak for local health departments because we are their member organization, which brings us to NACCHO is the professional home for local health officials and their staff. So local health officials are the lead staff person at local health departments. And as a membership organization, local health officials and their staff are able to join NACCHO. So thank you.
Okay. It is widely recognized that breastfeeding is associated with numerous health benefits for both infants and their mothers. The significance of this, the benefits that come from increasing access to support for breastfeeding so that mothers can meet their own breastfeeding goals, cannot be duplicated or replicated. We could not design a public health intervention that's so impactful as this. For the purpose of the work that we all do, breastfeeding is a public health issue, not an issue of individual choice. It is critical that we see our role as putting into place policy, environmental, and systems changes to make it possible for our mothers to meet their breastfeeding goals. This is our public health approach, and this is why breastfeeding is a public health priority, as well as a CDC priority. There are numerous federal resources and policies that call for increased support of breastfeeding, including the 2011 Surgeon General's call to action to support breastfeeding in the United States. In the 5 years that the call to action, since the call to action was released, we have continued to use it as the roadmap to guide our work and our funding. In response to the actions called for by the Surgeon General, the CDC Guide to Breastfeeding Strategies to Support Breastfeeding Mothers and Babies outlines a number of strategies to help guide public health professionals and breastfeeding advocates in developing interventions to increase support for breastfeeding mothers. This particular guide is our second edition, updated from the original guide published in 2005. The interventions outlined in the CDC guide, they're meant to influence the factors at many levels of the social ecologic model, which is displayed here. This social ecologic model was set up particularly to demonstrate the support that needs to be around breastfeeding. So the CDC guide can be found in each of the circles of the social ecologic model here, in an effort for us to create environments that support a mother and her decision to breastfeed. Mothers need support during the prenatal period. They need it during the hospital stay, when they return to work, and at various places in their community. Starting with the mother and the baby at the center of the model in the little white circle, each circle around that initial circle represents the influence of those who can provide support, starting with those who are closest to the mother and the baby. In other words, the family and the friends, and continuing to those that are most distant, as in the outer circle, the federal and non-federal organizations that all play a critical role in supporting breastfeeding. By providing support and protection for breastfeeding at all levels, we can help make it more likely for mothers to meet their personal goals to breastfeed and to continue breastfeeding. CDC provides resources for state and local health departments, community-based organizations, and hospitals to implement breastfeeding support activities. So here's a chart of the overall breastfeeding rates for the nation from 2009 through 2013, or over a period of 5 years. The breastfeeding support efforts of CDC, in combination with the efforts of many agencies, of organizations, and individuals like you across the United States, have contributed to increased breastfeeding in the United States. The most recent data show that in 2013, 81% of U.S. infants started breastfeeding, and this is compared to 55% 20 years ago. In terms of breastfeeding, the yellow line, in terms of breastfeeding for 6 months, just over half of the infants, or 51.8%, are breastfeeding at 6 months. And this is compared to less than 20% 20 years ago. The short of this is that there's been progress on breastfeeding because of every one of us working together to support breastfeeding mothers and babies. We know, however, that racial, socioeconomic, and geographical disparities still exist in breastfeeding. Here we show the black and white racial disparity in breastfeeding in the United States. The blue bar is representing non-Hispanic white mothers and non-Hispanic white infants, and the yellow is representing non-Hispanic black infants. While some progress has been made in narrowing the racial disparities, far fewer black infants start breastfeeding, and far fewer black infants are breastfeeding at 6 months compared to white infants. You can see from this bar chart that there is an 18% point difference between non-Hispanic whites and blacks. Keep in mind, though, that these data are for babies that were born in 2013. There has been a tremendous increase in efforts in the last 3 years to provide access to support for all families, with a particular focus on families with the greatest challenges. As we go forward, achieving equity and access to breastfeeding support needs to continue to be a strong priority for all of us. Health equity is a CDC priority, and achieving health equity and access to breastfeeding support is a CDC priority. We need folks working on every level, and we gave funding to NACCHO to support community-level efforts. While we and NACCHO come at the problem from the grass tops, so to speak, we are dependent on the efforts being conducted at the ground level or at the grassroots. Those of you working here at the grassroots are the voice for families, and you are the ones who put into place the policies and other supports to enable mothers to meet their breastfeeding goals. So let me just share a little bit about the disparity plan at CDC. In order to set up our plan to address disparities, we first identified what the greatest problem was. And while breastfeeding rates are showing progress, like I said before, the gap in the 12-month duration went up from before by about 5 percentage points. So our plan in order to address this is to continue to address racial disparities, to continue to explore racial disparities among women who begin breastfeeding, as well as to continue to monitor income and geographic disparities and explore avenues for community engagement, which is where you come in. CDC focuses its work on supporting breastfeeding through three main strategies. First, improving hospital support for breastfeeding. Second, implementing worksite support for breastfeeding. And third, increasing access to lactation care providers in the community. And to improve equity in access to breastfeeding support, we prioritize our funding to hospitals and communities serving populations with lower breastfeeding rates. Increasing breastfeeding support and breastfeeding rates among groups targeted through this work requires coordinated multi-level approaches because no one entity can do it alone, and this is why we have three main strategies that we use to address breastfeeding. And finally, I want to share with you a little bit about the work that we're doing across the nation. For the first time ever, CDC was able to provide funds to all 50 states, to Washington, D.C., and to multiple communities to support breastfeeding. 32 states have enhanced funding through a CDC cooperative agreement to work on improving hospital support, implementing worksite support, or increasing access to lactation care providers in the community. An additional 18 states and the District of Columbia received funding through a CDC cooperative agreement with the Association of State and Territorial Health Officials, or ASTO, to carry out these same priorities. CDC funding is being used to guide 94 hospitals through the baby-friendly journey, and this funding is represented by the gold circles that are surrounded by a red line. And finally, the stars represent 71 community organizations that receive funding through a cooperative agreement with NACCHO, the purpose of which is to increase access to lactation care providers in the community. I do want to mention that all of this work has a major focus on health equity. We have a good understanding of which population groups are at highest risk of not breastfeeding, and our funds require that priority be given to addressing these disparities by increasing access to breastfeeding support among these populations. NACCHO is using CDC funds to help communities increase access to peer and professional support at the local level, especially in areas with low breastfeeding rates, as well as to establish public health partnerships which can assist with building and supporting the infrastructure needed to provide adequate support post-discharge. Our current work with NACCHO is producing lessons learned on how best to provide community support for the 4th trimester or after the baby and mom are discharged from the hospital, as well as how to help communities identify targeted approaches that will work well in their communities. Funding was given, and now it is time to build the evidence. We look forward to sharing NACCHO's success stories with everyone, and we encourage you to stay engaged with NACCHO as we seek to disseminate the information that you have helped collect in your work with their active support. Thank you for the work that you do and your commitment to support breastfeeding.
Good afternoon, everyone. I'm very excited to be here today, closing the National Breastfeeding Month and the very last day of Black Breastfeeding Week. I hope you are able to engage your communities in this much needed conversation about breastfeeding throughout the month of August. So the goal, today's the kickoff of our public health breastfeeding webinar series, and the goal for this series is to increase participants' capacity to engage in changing the landscape of breastfeeding support. And this change starts by moving from thinking about breastfeeding as a parent lifestyle choice to an approach of taking collective responsibility for improving breastfeeding support for all families. In particular, we will emphasize the essential role public health professionals play in this effort. So the subtitle of the series is Breastfeeding in the Community. Throughout this webinar, you hear results from the Reducing Disparities in Breastfeeding through Peer and Professional Support project. So during this section, we're making the public health case for breastfeeding. Public health is concerned with giving everyone the best chance at a long, healthy, and fulfilling life from the very beginning to the very end. It includes all organized measures to prevent disease, promote health, prepare and respond to emergencies, and prolong life among the population as a whole. It works to reduce health disparities. A large part of public health is promoting health equity, including improving access to high quality care. Public health also prevents problems from happening through implementing educational programs, recommending policies, providing services, and conducting research and evaluation. And finally, it focuses on entire populations, not individual patients or specific disease only. So, when we consider breastfeeding in public health context, breastfeeding plays an integral role in preventing disease and promoting health throughout the life course for both mothers and babies. And as preparing for emergencies, the life-saving role of breastfeeding during emergencies is firmly supported by evidence. As you probably know, during emergencies, infants face risks of diarrhea, pneumonia, and malnutrition. Breastfeeding protects against those risks and improves food security for infants in this critical time. Infant mortality, infectious disease, cardiovascular, and other chronic disease are public health issues, as you know, and are major causes of death in the United States. Most of you are probably aware of the health risks of not breastfeeding. For infants, not being breastfed is associated with an increased incidence of infectious morbidity, and as these babies grow, they are more likely to be overweight or obese, develop type 1 and 2 diabetes, leukemia, and experience other chronic disease into adulthood. For mothers, not breastfeeding is associated with an increased incidence of premenopausal breast and ovarian cancer, type 2 diabetes, metabolic syndrome, and heart attacks. And do you know what the number one killer of women in the United States is? Yep, cardiovascular disease. There is a growing body of evidence that supports that the adult chronic disease originated early in life. There are some controversial results, but a growing body of evidence that being breastfed could be considered as one of the protective factors against hypertension, obesity, diabetes, and cardiovascular disease for baby later in life. The evidence for breastfeeding mothers, though, are well established, especially for women who breastfeed for longer durations. So, in addition to its short-term benefits, increasing breastfeeding duration rates can have long-term beneficial health effects at individual and population level. So, why don't we usually see suboptimal breastfeeding as a potential health risk behavior, along with lack of exercise, poor diet, smoking? These overwhelming health risks of not breastfeeding make the low breastfeeding duration rates a huge public health concern. And now, take a look at this picture. Let's say if this supportive grandmother here breastfed for a year, and then her daughter will breastfeed her baby for even more than a year. The potential reduction in risk for chronic disease is greatly increased for mother and baby. And if this baby girl grows up and breastfeeds her children, again, you can see the potential cumulative effects of these influences on health outcomes through generations. So this is the part of the life course approach. So my question for you to consider, you who work in breastfeeding, is do you partner to collaborate with any organizations that work in these different areas of public health? If not, think about the community agencies in your area and be creative on how you could be working together for improving the public's health. Back to our public health diagrams. Public health work to reduce health disparities. So health disparities are preventable differences in the burden of disease or opportunities to achieve optimal health, and they're experienced by socially disadvantaged populations. Health disparities are inequitable and are directly related to unequal distribution of social, political, economical, and environmental resources. Last year, we hosted a great webinar that talks about this in details. You can go to our website to watch the archive. So, minorities, especially those living in poverty, are disproportionately burdened by adverse chronic health outcomes. And as our nation becomes increasingly diverse, the need to address and reduce health disparities is more urgent than ever so we can reach health equity. Because by 2035, racial and ethnic minority communities in the United States are expected to become a majority. And CDC has a plan to address the breastfeeding disparities. So there's a lot happening to achieve equity in breastfeeding. So when we talk about public health breastfeeding, we talk a lot about equity in breastfeeding. It is important, though, that we recognize our own enablers in our own breastfeeding journey and identify the privileges we had that many moms in this country do not. So here's my story. Those are my two breastfed kids. The little one, Joey, is 18 months and is still breastfeeding. And I think that I reached the recommended breastfeeding rates because of the three major factors represented on these three pictures here. So my first facilitator was social norm and social support. I grew up in Brazil where breastfeeding is a norm. All my friends and family breastfed. My mom breastfed. My mom spent 6 months with me after each delivery. My husband is very supportive as well. My second facilitator was the Family Medical Leave Act, workplace laws and support, and that's the graphic there. I was one of those 69% of women that you see in the graphic who could afford to take paid and unpaid time off work, and I was able to stay home for 12 weeks with my baby. With that said, I'm still trying to digest another data from the Department of Labor that 25% of women in this country goes back to work within 2 weeks after delivery. I'll repeat so you can try to let this information sink in. In 2012, 1 in 4 women in this country returned to work within 2 weeks. I cannot imagine how I would have been able to breastfeed my children if I had to go back to work that soon. In fact, mothers who return to work before 6 weeks are 3 times more likely to stop breastfeeding. Anyways, then I went back to work and I had a supportive staff, breaks to pump, and a nice room to pump. And I know that despite the Affordable Care Act law, many women do not have any of these benefits in place. And my third facilitator was easy access to high quality care. I had lactation consultants available at the hospital and within 10 minutes of my house. Although I'm a lactation consultant, I did need an extra expert care support because I had had breast reduction surgery and I was unsure if I would be able to exclusively breastfeed, which I did. I look back and I see clearly how privileged I was to have all the systems in place so I can meet my goals to breastfeed until Joey is ready to self-wean. So if you were able to breastfeed as much as you wanted, or at least for 6 months, think about all the privileges along the way you had, and that many moms don't have. Do you think it is enough just to counsel on breastfeeding benefits and work on baby's latch and position with those moms? So now, I would like to invite you to take a deeper look into the lives of women in underserved communities. That was the target population of our project. So they had a couple, or or maybe all of these socioeconomic factors in their life. Think about how each of these factors act as unjust structural barriers that prevent women from implementing their choice and their right to initiate, but especially continue breastfeeding to the recommended duration of 12 months or more. We know that socioeconomic status and maternal education are inversely related to the likelihood to begin and especially continue breastfeeding in the United States. There have been marked improvements in the initiation rates, but the gap disparities, especially for duration, still persists. So, if you work in a hospital or private practice and do one-on-one counseling to mainly middle-class families, you're probably focusing most of your work on helping the individual mother and baby dyad make the physical act of breastfeeding work. You're implementing the evidence-based clinical knowledge of lactation you studied, and you probably do not have to think about all these structural barriers that affect breastfeeding rates, as our grantees who work in these underserved communities did. All our grantees had to provide peer and professional support to African American and underserved women. So, for that, they had to learn from their community and understand which structural barriers their clients face to access their breastfeeding services. Some of these barriers were safe and accessible location for their services, right timing of the support groups, other children that mom have, meals for the family if they're hosting support groups at lunch or dinner time, for example. They had to consider transportation. Some of our grantees, for example, they provided taxi vouchers, Uber rides, bus tokens, or just provided services where mothers go for other things already, like pediatrician's office, a church, library, and some even work at high schools. So you hear more about this in the results part of this webinar shortly. So disparity in rates exists not only in breastfeeding. For example, infant mortality has a disparate impact among African Americans. Black babies have more than double the risk of dying before their first birthday than white babies. Chronic disease are also unequally distributed. Cardiovascular disease death rates are highest among African Americans. In 2010, African Americans were 30% more likely to die from heart disease than whites, and black women are 1.6 times more likely than white women to have high blood pressure. So, breastfeeding is beneficial to almost all mothers and infants, but the benefits may be significantly greater for communities that are disproportionately affected by adverse health outcomes that could be improved with breastfeeding. Disparities in access to health services affects individual and society. The inability to access timely care is due to lack of available, accessible, and affordable high-quality healthcare services. And you hear from Shade and Ikia soon that it is this access to services was a big part of our project. They had to provide free, accessible, high-quality breastfeeding care to those who needed the most. You may seen this picture, or at least part of it, before. It shows the concept of health equity. So the first box is equality or sameness. It's giving everyone the same thing. For example, a pair of shoes. For breastfeeding is providing all moms with the same services. For example, a support group at a high-end retail mall at 10 a.m. And then you promote, oh, everyone is welcome. Equity, the box in the middle, shows the concept of fairness. For example, giving everyone a pair of shoes with a size that actually fit them. So for equity in breastfeeding support, it means giving services that mothers will be able to use, such as providing an additional support group in mom's underserved neighborhood in the evening, provide dinner and childcare to her other children. So working mothers in these communities have a chance to attend. But really, you need to ask that specific community you work what their needs are, or in other words, what their shoe size is. Don't assume every community needs the exact same thing. And the last box shows removal of structural barriers impeding full access for all, no matter their circumstances. So this would be a country with fully paid maternity leave, high quality, accessible support in all neighborhoods, breastfeeding friendly communities with breastfeeding friendly OBs and pediatric practices, supportive workplaces, and where all hospitals are baby friendly. That would be wonderful, wouldn't it? So public health can address structural barriers and prevent disease through programs, policies, and researches. These examples I will talk about works on changing the policy systems that enable mothers to breastfeed. It restructures the environment to make the healthy choice the default choice. It makes breastfeeding the easiest choice for parents. A good example is the Baby Friendly Hospital Initiative. It's a worldwide program with its own set of policies to reduce health disparities within an institution because all infants are born into a similar environment that promotes breastfeeding. There's also the Affordable Care Act, which includes breastfeeding support, supplies, and counseling, affordable or free of charge. Also, there's the break time for nursing mothers at work, and another far-reaching program that support underserved breastfeeding women and families is the WIC program. And finally, public health focus on entire populations, not just individual mother and baby diets. And this one is one of the main differences between individual counseling and public health. So here, public health reaches broader segments of society and are more effective because they require less individual effort. So public health implements population-wide interventions that have greatest impact and emphasizes policies and systems change, environmental enhancement, infrastructure building, and easy access to evidence-based counseling and support. So for entire populations, what do we mean? For example, if you are the World Health Organization, your target population for your public health programs is the whole world. If you are CDC or Health and Human Services Department, your population is United States and territories. And if you are one of the Nature Breastfeeding grantees, it may be one of the 69 communities across the country, such as African Americans and underserved moms in the 8 counties of South Central Kentucky, or a specific neighborhood predominantly Hispanic in Chicago, or even the 250 babies being born per year in a South Pacific island between Guam and Philippines. This is the Republic of Palau. It's a U.S. territory. So, to conclude this part of presentation, here's a little timeline of the last century of breastfeeding in public health. So, breastfeeding has been promoted as public health issue widely twice in the United States. First in 1920s, when babies were dying at alarming rates for being fed contaminated cow's milk. So here, breastfeeding was promoted mainly to prevent diarrhea and infant mortality that cow's milk was causing, but not because they recognize the benefits of breastfeeding. Then again in 2000s, right after the release of the US Surgeon General blueprint to increase breastfeeding rates, The public health breastfeeding promotion campaigns were based on the evident health benefits of prevention and protection against several diseases and conditions. So you see an example of the 2004 National Breastfeeding Campaign from the Office of Women's Health. It was babies were born to breastfeed. This one in particular is stating that breastfeeding prevents obesity. Very clever. So the Surgeon General blueprint started giving voice to the disparities in breastfeeding rates and called as a serious public health challenge. It started the baby-friendly hospital movement in the United States. It called for all sectors of society to act and take responsibility. This blueprint was updated and turned into the Surgeon General call to action to support breastfeeding in 2011. And they had a whole section on breastfeeding from the public health perspective and called for a better public health infrastructure to support breastfeeding. And this is one of the things that guided CDC's work on breastfeeding. In 2007, with an update in 2013, the American Public Health Association developed their policy called A Call to Action on Breastfeeding, a Fundamental Public Health Issue. They talked about disparities, access to breastfeeding support, and associated these disparities rates to persistent social, political, and economic barriers, linking the Affordable Care Act coverage and workplace support laws as reducing some of these barriers. In 2012, the American Academy of Pediatrics, in their updated Breastfeeding and Human Milk statement, also posed breastfeeding as a public health issue instead of individualized lifestyle choice. They consider breastfeeding as preventive medicine. ACOG and other major medical organizations also have statements including breastfeeding as a public health issue. I would like to consider including the partnership between CDC and NATO in this timeline for 2015 because of this unique public health breastfeeding project you hear about next. It was the major coordination of nationwide community breastfeeding implementation, and all of these implementing agencies were receiving exclusive public health training and technical assistance to truly understand and address structural barriers that the families they were serving were facing regards to breastfeeding support. So now we will transition to Shade, program analyst of the Nature Breastfeeding Project, to give some background of this project. Oh, and of course, there are much more work happening nationally, not just what's in that timeline. So that there's work happening nationally and state and local levels. Over the last few years, several federal policies have called for increasing support for breastfeeding, recognizing many health benefits of breastfeeding, and the collective responsibility of multi-sector organizations to support women who want to breastfeed for the recommended rates. And like I said, the 2011 Surgeon General Call to Action is central to these documents, outlining 20 action steps to support breastfeeding, and it's continue guiding the work at CDC. Here's a list of resources used in this presentation that gives this framework of public health in breastfeeding. And thank you. This is one of my favorite quotes because it links not just the lifetime effect that breastfeeding will have in one person, but in a whole population, and also the economic, and we know that we can't talk about health without talking about economy. Thank you.
The goal of the Breastfeeding Project was to increase access to peer and professional support in African American and underserved communities in the U.S. This was achieved by, one, increasing community-level implementation of evidence-based and innovative peer and professional breastfeeding programs, practices, as well as services. Two, by increasing awareness through dissemination of lessons learned. And finally, by increasing local, state, and national level partnerships to promote breastfeeding. These are the core activities Nature did in relation to the Breastfeeding Project. We developed and disseminated the RFA, selected grantees, provided funding to those selected, and provided training and technical assistance throughout the project period. Initially, our goal was to fund 70 community-level demonstration projects or organizations. We received more than 150 applications, selected 65, and provided awards to 63 organizations in year one. In year two, a total of 69 organizations were funded, 63 of whom were part of the initial cohort of grantees. 6 organizations were funded to work with Empower Hospitals in year two. This map indicates that Nature offered 62 sub-awards to 69 organizations in 32 states and 2 territories. These territories were Washington, D.C. and Palau. From January 2015 through June 2016, Nature staff provided various forms of training and technical assistance to grantees. 5 regional meetings and 1 closing meeting was held with all our grantees. We conducted 39 site visits and hosted a total of 39 peer sharing calls. During peer sharing calls, grantees could interface with other organizations doing similar work. Nature also provided one-on-one technical assistance during quarterly call with each organization. Our team hosted several webinars on topics such as cultural humility and community engagement. We also provided grantees with information on breastfeeding-related webinars, ground rounds, and events organized by various organizations at both the national and the local level. Throughout the duration of the project, all our staff provided scheduled one-on-one as well as ad hoc technical assistance on work plan deliverables, budget revision, and other aspects of program implementation. During 18 months of the project, 1,500 plus hours of technical assistance was provided to grantees by the entire breastfeeding project team here at Nature. More than 75% of support given to grantees was around pre-implementation, finance budgeting, and program implementation. An example of a pre-implementation support could be working with a grantee to ensure that the proposed objectives in the work plan are aligned with the approved budget. The type of Nature support most valued by our grantee was the face-to-face training or in-person support offered by Nature staff. These training sessions, which occurred either at the opening meetings held in different regions or at the closing meeting, were very valuable to our grantees. Grantees reported peer networking, which typically occurred during peer sharing calls, to be very useful. Implementation assistance was offered by Nature staff on a daily basis and at times during site visits. So, looking at the data that the grantees shared with us throughout the project period as well as in their final reports. The majority of the organizations funded by Nature, more than 65%, were either local health departments or community-based organizations. However, several hospitals, community health centers, or federally qualified health centers were also funded to provide community-level peer and/or professional breastfeeding support. Our grantees provided support through one-on-one or individual support and support groups. The data shown throughout this presentation are for all our grantees, including those who worked with the Empower hospitals. There were approximately 93,000 recorded one-on-one encounters with both breastfeeding and pregnant moms. And as you can see, at the beginning of the project, many of our grantees were seeing very few moms in terms of one-on-one encounters. But by the end of the project, you can see that the number of attendees to these meetings or to that were being seen for one-on-one consultation has increased dramatically. And sometimes moms may be seen by on multiple occasions for one-on-one consultations. Our grantees hosted over 3,000 breastfeeding support groups throughout the duration of the project. And finally, our grantees were able to serve more than 12,000 women. And again, as you can see from this graph, in the beginning, the amount of women seen in the support groups were very few, but by the end of the project, it had increased significantly. The average woman served by our grantees was between the age of 25 and 29. This is true for women who received both one-on-one and individual support, as well as those who participated in the support groups. Furthermore, the majority of the participants who received both individual and group breastfeeding support were African American women. These are pictures of some of the pregnant or breastfeeding women who were supported by our grantees. And these pictures are from Monroe County Health Department. This picture is from Reaching Our Sisters Everywhere, or ROSE. Our grantees supported approximately 36,000 women with initiation of breastfeeding. At 3 months, grantees reported that more than 8,000 women were still breastfeeding, with more than 2,600 breastfeeding exclusively. At 6 months, close to 8,000 women were still breastfeeding, while approximately 2,500 women were assisted with initiation of breastfeeding. This data highlights the importance of providing continued breastfeeding support to moms beyond the first few months postpartum. And at 12 months, more than 25,000 women, 2,500 women, continued to breastfeed. Furthermore, due to the capacity of grantees, or the limited capacity of grantees, some mom may have been lost to follow up. Our grantees provided an array of services in a variety of settings to support women during the prenatal and postpartum period. Approximately 70% of our grantees provided prenatal education to women in their communities. By working with prenatal women, healthcare staff have an opportunity to impact a woman's intention to breastfeed or help the woman develop breastfeeding goals. Family Health Center of Worcester was a grantee that was able to successfully connect moms who attended the Center in Pregnancy group to its baby cafe. The board-certified lactation consultants and peer counselors who led the baby cafe were supported through funding from the Nature Grant. 45% of grantees provided breastfeeding support during home visits, while 30% visited hospitals to provide breastfeeding support to women. Home visits often allow the peer and/or professional staff to engage other family members or support persons who may be present on how best to support moms with breastfeeding. The hospital visits can ensure that there is a continuum of care beyond the support a mom receives at either a WIC or a Center in Pregnancy group. All our 9 Empower grantees worked with either one or more hospitals. Approximately 50% of our grantees utilize technological tools to engage women seeking support and information on breastfeeding. For example, several grantees, including Children's Home Society of Florida, Family Support Hawaii, and Wisconsin Women's Health Foundation, developed text messaging scripts. And 36% of our grantees provide text-based breastfeeding support. At Wisconsin Women's Health Foundation, a registered nurse and a certified lactation consultant sent personalized text messages to moms who had questions related to breastfeeding. In addition, nurses working with another grantee, known as Teen Outreach Pregnancy Services, created their own Facebook page, which they used to interface with young moms. And looking at the staffing and capacity of our grantees to implement these programs. A lot of manpower or man hours went into implementing programs at the community level. The majority of the staff who worked on the project did so in kind, and based on the information provided by our grantees, most of the staff were either certified lactation educators or program administrators. Peer counselors were the largest category of staff who were contracted to work on the project. Overall, 42% of our 69 grantees provided training to peer counselors, and more than half of the grantees provided trainings to nurses. In addition, 28 grantees, which was more than 40%, provided trainings to visiting staff. And partnerships. Approximately 830 unique partnerships were either developed or enhanced by our grantees, and 15% of our grantees established partnerships with local health departments, while 13% of our grantees established partnerships with hospital-based clinics and community health centers. All our 9 Empower grantees worked with one or more hospitals within the community. It is very important to note that the strong partnerships that were established by our grantees during this project. And this is something that we'll continue to explore in our other work here at Nature.
Well, it's time to figure out what we learned throughout this entire project. We've already heard from um, Harumi about the public health perspectives on breastfeeding. We also heard from Carol about CDC's priorities, and we've heard from Sade about what were some of our core numbers. And now it's time to think about success and lessons learned and what's next. And so I like this graphic because I think it's a perfect example. It's true. People who are on the outside and people who are starting a project often think that success is just a straight line, like you start and off you go. But very often it's this wiggly, squiggly, crazy-filled process that still gets you to the end game, but there's often a story. And so let's talk about the story of what's going on with our grantees. And so in this process, NACHO did particular activities. NACHO funded the different breastfeeding projects across the country. NACHO provided training and technical assistance. We've also shared lessons learned, and we did a lot of national partnering activities. In terms of funding, NACHO funded through 2 separate award streams, and Sade mentioned this earlier on. For the communities that were funded for 17 months, the overall award amounts were just about $20,000 per year, and $2.5 million were awarded, and grantees requested and received reimbursement for just about 2.2 million of the 2.5 million that had been awarded. And for a much shorter period, 5 months, starting just about February of 2016, we awarded 9 additional grantee sites, and they received funding to work in partnership with local health. The local health departments received funding to work in partnership with hospitals who were funded through CDC to work on becoming baby friendly. And so those awards totaled just about $44,000 average. And I like to call all of this conversation money because in the grand scheme of things, $20,000 or even $44,000 over such a tight window does not make a sustainable program. And so many of the grantees already had to have activities or projects in place or ready to move to the next stage in order to get the biggest bang for their buck and to make sustainable shifts along with their projects. And so you've likely seen this slide before. It really just talks about the different types of activities and work that grantees utilize their funds to kind of move forward. One main component of this project is that everybody who received any funding had to be providing direct support services, direct support, lactation support services to women and families within their community. And so while every grantee did that, Many others went on to do other supporting activities. And if you stick with us throughout the entire webinar series, you'll get to hear more and more about the individual work that different grantees were able to achieve throughout this process. NACCHO provided, in supporting grantees throughout these processes, NACCHO provided training and technical assistance over the course of the 17 months or 18 months really, that 17 months for the longest grantee, but 18 months from our perspective, that we provided training and technical assistance. And so um, that work, as Sade mentioned, grantees preferred face-to-face encounters with us, and we did that in three ways: through project site visits and also through a closing meeting. And prior to kickoff of each grant cycle, of each new grant, we also had an opening meeting for grantees where we really talked about a lot of the grants administration process, and that was an important lesson learned. And I think it was a critical factor in helping us to be able to move the work forward. I think that there's more opportunities for us to do even a better job were we to work with the next cohort of grantees, but I think that was an important part of the work. All grantees had the opportunity to work directly with program analyst, and if necessary, a lead analyst via quarterly calls. We also had peer sharing calls where grantees had the opportunity to work and encounter one another. And we also did several, three webinars where we had almost 800 attendees altogether. We made resources available through our breastfeeding community of practice, and all in all, it was a great process, and we look forward to being able to continue to provide capacity building assistance in one way or another to organizations still in working at the community level. NACCHO worked very hard to disseminate project results and findings, and we did it via numerous outlets. We did, over this course of the time period for the first 2 years of funding, we did 14 international or national conference presentations, and that might have been oral or posters. We did one journal publication, and we distributed information through 2 different NACCHO media outlets. We also engaged in a breastfeeding public health partners group, which are other national level organizations, including the United States Breastfeeding Committee, the Association of Maternal and Child Health Programs, Carolina Global Breastfeeding Institute. You see all of the names here, and so I won't read them all off of the screen, but these are all organizations who are working at the national level. They're national nonprofits or researchers, in case of CGBI, Carolina Global Breastfeeding Institute, who are working at the national level on maternity care practice issues, peer and professional support issues, or workplace policy and accommodation. And by coming together, we were able to coordinate and collaborate so that we can move forward on these initiatives together, and that we can partner appropriately to move forward the work. So other things to know are this has been a successful process for NACCHO in many ways. It gave us a great opportunity to work closely with our project officer from DNPAO. We also had the opportunity to work with 72 different demonstration projects, and each community brought a different flavor, a different experience to the table in terms of size, capacity, level of experience, target audience, and their overall reach. And so for NACCHO, the benefit of that is we were able to develop a strong level of expertise in providing various training and technical assistance to very diverse community level groups. And that's something that we look forward to continuing in this next phase of the project. And so before we talk about what we're going to be up to next, let's talk about what grantees had happened and what unfolded for grantees in these first 17 and these 18 months of this project. And I think that somebody in your registration, you were able to ask us questions, and someone said in their question, how do you measure success? Or is it just about the outreach numbers? And absolutely it isn't. And I like this image here with these 2 little gray rabbits. Success is not simply measured by how many women were reached or the number of support groups hosted, not even by the number of people lactation service providers trained. all of that is important. And some grantees weighed in huge in terms of the number of people who they reached on a monthly basis. And other grantees didn't have as a large a number impact in terms of the number of people reached, but they were really able to change some of the underlying systems or the infrastructure around their projects, which I think has a longer term potential impact on being able to provide sustainable services to their communities. When we talk about public health solutions to low breastfeeding rates in underserved communities, Harumi really touched a lot on the fact that there are structural barriers and hurdles that we have to get over in order to be able to meet the needs of the communities that we serve. And it's really that work that's happening under the surface that has a large bang for your buck in that domain. And so when we're thinking about what happened, there are barriers and facilitators to the work. And so let's talk about what are some of the core barriers that we got to see in this process. And we may have some opportunity at the end, maybe during the Q&A, to kind of go over how grantees were able to navigate some of these issues. And so starting from the top, I think that some grantees started this project with a strong desire to work within their community, but very often there wasn't enough innate research or understanding of what was actually the community context. Maybe you had your own little project. Maybe you only had your own WIC site or your own Healthy Start site or your own FQH, Federally Qualified Healthcare Center, and you wanted to do your project right within the clients within your agency. And I think that it was important, and something that we learned throughout the process is that it's important to understand what else is happening in your community, so that you can create the best partnerships and being able to get the best wide range of services available to your moms, and being able to increase everybody's capacity and skill set to be able to serve the families in your community. Client engagement also became an issue. So recruitment, retention, and we have a slide later on where we're talking about facilitators, where we'll talk about what were some of the things that grantees did to deal with that. I mean, weather challenges and location and times of meetings, all of those things really had an impact on maternal recruitment and retention or client engagement overall. And some of that has to do with making sure that you understand what the needs of your community are. At one of our earlier webinars on community engagement, one of our grantees from St. John Providence Hospital System in Detroit, Jennifer Day, talked about having meetings that were empty until she had an opportunity to really sit down and talk to moms and begin to understand what their needs were. And so they were able to shift their daytime meetings to an evening meeting, and they served food and had childcare, which really changed what the group dynamic was and how many people came out. They now have a very full group with lots of community engagement and connection, but it really had to do with beginning to understand the community and make those connections. Achieving buy-in from the community, from providers and allies are also very important. I think that there are some grantees who really had that going on from the very beginning, and there's some who never got it achieved at the end. And that really had a lot to do with, especially in the context of allies, and really it should also say leadership here, because having organizational leadership who is got strong buy-in around promotion and support of breastfeeding is a really critical component of this work, and we'll circle back to that a little bit later on. A narrow focus on breastfeeding. I know you're thinking, this is a breastfeeding webinar. What do you mean a narrow focus on breastfeeding? What I mean is that although we are promoting breastfeeding, it's very often that we have seen through this work, and not just working with communities, but even working at the national level, that individuals and organizations that work in breastfeeding, they tend to partner very closely and talk very closely to other organizations who work only in breastfeeding. And it's important to kind of open up just a little bit at first, even, right? Open up a lot, but open a little bit, and make sure that you're talking and partnering with organizations that can take you to the next level, so that you can expand your reach. If you're talking about breastfeeding, we know that breastfeeding, because Harumi told us earlier, and you already know from your own research and experience, breastfeeding has an impact on infant mortality. Breastfeeding has an impact on child obesity and therefore adult obesity and therefore chronic disease. And so let's begin to have a wider, broader focus on who we can partner with in the community so that we can move forward a larger collective agenda. So establishing and managing partnerships, that goes hand in hand, that's a barrier. So grants administration, so what does that mean? Some organizations were bureaucratically heavy, very, very large health departments, and also very large hospitals had a very difficult time processing contracts in a timely manner, which led to less than optimal spend down of the budget, especially in that first year of the project period for those grantees that were in that $2.5 million organizational side, the grantees that worked with us for 17 months. And so heavy bureaucracies provided a burden to moving the work forward. All of these projects required a partnership, and it's important to look at your partnerships to kind of think about who's the best partner to move the project forward. And it may not necessarily be the large or heavy bureaucracy. It might mean the smaller organization that's more nimble. Now let's talk about small organizations. Sometimes if your organization is really, really small, it's difficult for them to move the project forward also. This was a subaward. As a subaward, it means that you have to spend the money and then send in your receipts to get reimbursement. And so we had some grantees with very, very small operational budgets where this was really a disaster. And as the funding agency, we had to renegotiate how we work with them. Instead of doing quarterly or even bi-monthly reimbursements, we had to switch to a monthly reimbursement stream in order to make sure that that organization could stay financially viable and stay engaged with this work. Staffing issues, recruitment, hiring, turnover, and training, those became issues. This was a short turnaround contract, and it was two separate contracts, especially for those with 17 months of award. And so recruiting staff, getting them hired and keeping them hired during the break in the contract where it was time to redo, especially if you were bureaucratically heavy, provided a challenge. And so something for NATO to consider were we to do work like this again is how to have a contract that might extend over a longer time period so that we don't necessarily have a gap in service for our subawardees. Staff training. We had some grantees who came on board saying, "Yeah, we're going to train our our hospital staff or our clinical staff for 20 hours of training to become CLECs," only to find out as they got into the process that they don't have the time to take off of their clinical duties or their core duties in order to do a 20-hour breastfeeding training because maybe you didn't have the adequate leader buy-in who could make that possible, cycling back to the upper right corner. And so implementation capacity challenges were another issue. Grantees really, in developing a work plan, what we learned is that not all organizations or not all people present from particular organizations who work with us had really core understanding about how to link activities to work plans and how to flesh everything out. So it will be clear for us as funders and for us to present to CDC how this work would move forward. And so I think that that was a capacity challenge that we see a need to continue to work with at community level organizations. And also, this is a huge one, the inability to articulate success. It's really, really important in this process that we be able to share the lessons learned and that we be able to make community level funding a priority and something that continues to happen. And in order to do that, we have to be able to articulate that success. And we need to be able to articulate success that's happening above the surface, all of the greenery, and articulate the success that's happening below the surface, that big, thick, heavy carrot. Okay. And so let's talk about some of the facilitators that made doing this work possible. I love when I'm at the airport and I encounter one of these people movers. When it's really late and it's completely empty, I can walk fast because I never carry bags that have to get checked. So I just have my carry-on and I can move really fast on these moving, I don't know what you call those, but it's not an escalator, but I call it a people mover. I love it. I don't love it so much when I'm running late for a 12 o'clock noon flight because it's always full and packed and it's much slower than just walking along using your own 2 feet power. So the point I'm making here is that most of the things that I'm about to point out as facilitators, they also translate to barriers when viewed from the flip side. So one key facilitator I would say is enabling access to quality care. And I think that that was a core thing that happened with many of our grantees. No matter where they were, whether you were in a rural community like Arkansas Breastfeeding Coalition, and you were creating a space where you were doing virtual breastfeeding support by giving your peer counselor, who later became a CLC, um, a tablet so that she could connect back to an IBCLC who was in your main city, which I can't think of what the main city name is at this moment, but using tools like that to really create a space where we can enable access to high quality care is important. Brooklyn Hospital Center, very, very huge WIC site. So big and so robust and full that moms who wanted to contact their peer counselors weren't able to reach the peer counselor because the phone lines were always busy, and so through this funding, they made cell phones available to all of their peer counselors, so that the clients could reach the moms. The mom clients could reach the peer counselors directly. And that also included developing text scripts and phone scripts so that those peer counselors were adequately monitored also through that process. We had grantees that did home and hospital visits. Maternity Care Coalition were able to do home visits because they trained they trained champions among their different home visiting staff in order to be able to best support moms. We had grantees that also did hospital visits associated with this project, so they were able to kind of bridge the gap between. And we'll hear from Esperanza at our next um, webinar, but they were able, with that type of support, to bridge the gap between community, hospital, and back to community. Another grantee that was able to do that was St. John. We had 2 sites in Detroit area, both St. John Hospital System programs, and both of them had community and hospital components. So grantees who made family involvement a welcome component of their group supports did very well. Grantees that made child care and food, especially, available did very well. Providing prizes and incentives were great. Now, on the flip side, we had grantees who did small things like offering a token or like a charm on a charm bracelet or a charm necklace for every milestone that a mom achieves. That's a great prize. Or offering diapers for moms if you're working with mom families who are low income, and most of ours were, and they need those type of things, offering diapers, great ideas. We had grantees who may maybe purchase some pretty large supplies, strollers or pack and plays and things like that, and offering such a large prize is not always best, especially if you don't have the capacity to sustain those type of efforts. Transportation vouchers. We had one grantee, Family League of Baltimore, in order to bring moms together for one particularly important meeting that they had. They brought all of the moms in using Uber, and that's actually a pretty creative and different way to use funds. And so enabling access to care through all of these different ways are pretty important and critical. Another key facilitator is establishing community level partnerships. We had 830 local partnerships formed or enhanced via this project. The partnerships are at different levels of strength and integration, and that's normal and necessary. But partnering and having, even if it's just partnering, that's one thing, but having meetings and networking with your partners in the field so that you know each other and you feel confident and able to refer to each other's service is a critical part of this process. Alameda County, and I think that you will hear from them probably for our December webinar, did a really great job of building strong community connections in that way. And so another key facilitator in this process are building supportive policies, systems, and environments. And that's a lot of the work that's happening under the surface, policy systems and environments. And so policy shifts really require a champion of some sort. Very often, um, getting a new policy written for your federally qualified healthcare center or for your local health department to become breastfeeding friendly, a breastfeeding friendly FQHC or a breastfeeding friendly local health department. That requires that you have somebody in a leadership role within your agency or your organization who's going to be an advocate for this process. And that's so champions are necessary. Um, and moving on from there, um, system shifts are necessary. We had some grantees that they were able to change the way that they do the work within their agency. Maybe it started with a policy shift and it went on to become a shift in the way that they do business. We had some grantees that they were able to leverage funds with other organizations in order to put in electronic medical record systems so that they could better track their client. That more so happened for the clinical sites, but that's an example of a system shift that really changes the way that business happens. And when that happens, that tends to have some level of sustainability. Very often, in order to make this type of shift or thing happen, you have to have some financial resources to back the process. Finally, environmental shifts. I think that more than anything, environmental shifts take time, and the policies and systems have to be in place so that you can have an environment that feels good and comfortable to moms, where all of the staff are on board. Um, so let's use an example of a breastfeeding friendly, federally qualified healthcare center. It means that when a mom comes in and she's pregnant, that all staff are ready to engage her. Hi, Lisa, how are you? Thank you for coming in. Um, you're going to be checking in and you're going to be talking to Dr. Alvarez. And here's your sign-in sheet, and your forms have information about, hey, are you planning to breastfeed? Or what are your breastfeeding goals? And that gets checked in when they go in and they talk to their care coordinator. And when they get in to see the doctor, it gets talked about again because everybody at every level within the organization is doing their own part to support this process. And it becomes, and all of the pictures and everything that's going on within the FQHC, everything is aligned in a way to support this mom and to support this community and being ready and able and attuned to the idea of breastfeeding. And that takes time, champion, and sometimes resources. So what are some of the lessons learned that we have throughout this entire process here? And these are lessons for both NACHO and the communities at large. We learned that it's important for us as NACHO to identify implementation issues at the time that we give a notice of award so that grantees know that they're going to have to work on stuff, and we let them know early on. We should require sustainability planning within work plans at the very onset so that we're not talking about sustainability midway through the project. I think that funding amounts, not I, but we think that funding amounts should match grantee fiscal and technical capacity. And this is especially the case when we're talking about grantees that maybe are newer to this work or who have very, very small operating budgets. If you have a $15,000 operating budget and a $15,000 award and you have to spend money in order to get reimbursed, that's not a good fit. And so there needs to be better matching, and we need to understand those things earlier on. We learned in this process that sometimes the organization that got funded was not necessarily the partner that did the core work. And I think it's really necessary that we engage partners very early on. Sometimes we didn't get to know the partner until we went out to a site visit. And I think it's important that we get to know the partner earlier on through phone calls and other opportunities to engage. We also need to work earlier on with grantee fiscal agents so that we can ensure proper spend down. We need to require that grantees articulate their plans to leverage funds because that's an important facilitator. Leveraging funds is also a facilitator, and important that grantees think about it early on. we require that all grantees have a partnership objective. And as you can see, there are 830 partnerships established or strengthened. And so we need to maintain that so that we can even see better results there. We need to support grantees in disseminating results. As I mentioned earlier, as a barrier, grantees had an inability to really articulate the important work that they achieved in their community, and we need to support grantees better in doing that. And also, if we're thinking about policy systems and environmental shifts, we need to give some thought to focusing funding on initiatives that really do work on just policy systems and environmental shifts, even if it doesn't provide direct training or direct service delivery to moms, because that's a lot of the under the surface carrot work. So what's going on with NACHO? So those are the lessons learned, and so what are we going to do with all of that information? So between September 2016 and June 2017, this is what we're going to be up to. Our current project goals have to do with building capacity, disseminating lessons learned, and continuing to partner for success. So in terms of building capacity, we're going to be doing this webinar series and continuing education. um, Credits are pending for the following series, for the following topics within the webinar series. We are also going to be doing capacity building briefs, which will be available electronically on our breastfeeding webpage, which is breastfeeding.nacho.org. They're not there yet, but they're coming. And also, where applicable, we'll also share resources, templates, and tools that community level organizations can use to support the development of their work. And for example, there we have our breastfeeding support services tracking sheet so that you can document women or families who come to your meeting. And so maybe we can make those type of templates available for community level organizations. We also really want to work on disseminating lessons learned. So NACHO had many various activities that we're going to be doing in terms of dissemination. We're going to be writing the breastfeeding policy statement for our organization. We're going to be doing a final report to CDC, and also 2 manuscripts for submission to peer-reviewed journal articles. Our goal is to also present at least 1 national conference this year and to support former grantees with disseminating results. So what does that mean? So what are your opportunities, former grantees? Well, NACHO has many outlets for grantees to shine. We have stories from the field, which is an opportunity to talk about successes and lessons learned from demonstration projects that you've worked on with NACHO. It's pretty straightforward, less than 1,000 words. We also are going to have grantees will have the opportunity also to support, to submit a manuscript along with NACHO for our journal articles. And we're going to likely be submitting to the Journal of Human Lactation. NACHO has a model practice program, a model practice application, and it's only for local health departments. But very often, even when the grantee was a community-based organization, you partnered strongly with the local health department. Just that partnership and how you were able to make that partnership work and what you were able to achieve through it, that in itself is a model practice. There are not many things going on in the model practices database for NACHO that really talks about breastfeeding. So this is a really, really great opportunity to make this available. The model practice window opens on October 1st, and so you can look out for an email from us inviting you to participate in that application process. Also, grantees have the opportunity to present on NACHO's webinars or webcasts so that you can share your results of your own projects via our webinars. And most importantly, not most importantly, but also importantly, grantees can request funding from NACHO if you're going to be doing a live presentation that talks about your funded activity. So we're also going to be continuing our work with the Breastfeeding Public Health Partners. Really the goal is to maximize the federal dollar investment in breastfeeding. And so we're going to be establishing a charter, defining measurable objectives for our partnership, and reviewing the need to engage other organizations in order to move the work forward. And that will really happen after we figure out what our charter is going to be, and we're doing that work is ongoing. So next steps are, the final thing that you need to know is our next webinar is going to be taking place on Wednesday, October 12th, 2016 at 2 p.m. Eastern Standard Time. You can register at your convenience It's called Breastfeeding in the Community, Closing the Care Gap. And the goal of that webinar is to address varying mechanisms that can be used to create a continuum of care to promote and support breastfeeding in underserved communities, discussing both internal and external care continuity in hospital and community settings. The webinar will also explore how breastfeeding support and promotion services can be integrated into allied public health programs to create sustainable solutions to the care gap. We will feature two of our grantees who implemented and are sustaining a greater continuity of care system, not only within hospital community, but also within their own systems. The learning objectives are to define continuity of care from a healthcare and public health perspective, to describe the role of internal and external partnerships, and to identify at least two strategic public health entities, two strategic things that public health organizations or entities can do in order to enable broad access to breastfeeding support and services. The continuing education for this series is pending, and we are excited to be able to continue to work with you, and we hope that you join us for our next webinar on October 12th.